Hello, everyone. Our topic today is about introduction to pain interventions. These are the objectives of my presentation. We'll talk about definition of pain, total pain, the WHO analgesic letter, modified, multimodal analgesia, spinal needles, neurolysis, Sunderland Classification, radiofrequency versus cryoneurolysis. And we're going to end our presentation with a clinical vignette. Pain medicine, is it art or science? According to Armand Trousseau, Dr. Armand Trousseau is a very famous uh, French physician. A little less science, gentlemen, and a little more art. Definition of pain. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. This is basically the definition of the International Association for the Study of Pain. How about total pain? This terminology was put forward by Dame Cicely Saunders, who coined the term total pain and suggested that pain can be understood as having physical, psychological, social, emotional, and spiritual components. The combination of these elements is believed to result in total pain experience that is individualized and specific to each patient's particular situation. So pain is both physical and non-physical. We're going to focus in this presentation on the physical aspect because this what is more important to us as interventionists. We have three types of physical pain: nociceptive, which basically relates to tissue damage, inflammatory, and a neuropathic. And the neuropathic is a pain which arises as a direct consequence of a lesion or a disease affecting the somatosensory system. Why this is important to the interventions? Before you stick a needle in the patient, you should have an idea, why am I putting this needle and where? And thus, you have to start thinking about, do I need to block the nerve, or I'm going to need to block or inject the joint itself? Do you see? Also, do we need to put steroids, for example, or not? Is this an inflammation? Or do I need to put PRP, for example, to promote the tissue regeneration? So there are so many questions that will encounter here when you decide to put a needle in a patient. And this is why you need to have an understanding to what is, nociceptive versus inflammatory versus neuropathic pain. This is basically the WHO analgesic letter modified. They added another step, which is step 4, where they left a place for the injections and the blocks, okay, that we're doing. So we have step 1, as usual. Step 2, you add weak opioids. Step 3, you add strong opioids, and then you have step 4, which is basically the interventions. In acute pain, as you see, you go from above downwards, while in chronic pain, we're talking about non-malignant or cancer pain, we go from below upward, which makes a lot of sense. Because if you have, for example, a sickle cell crisis in the ER, you're not going to start with non-opioids. I mean, you're going to give him morphine. You're going to start from the highest level, and then as the patient gets better, you start to cut down your medications. Okay, we're going to talk about multimodal analgesia. This is a very important concept as well. And it's basically multimodal analgesia comes with different colors. You know, we have transduction, we have conduction, we have transmission, we have a modulation, we have perception, and we have the CNS responses. Each step can be uh, utilized with either a medication or an intervention. Okay, we're going to talk about pain interventions. So we have some questions about pain intervention. First, what's your target? Are we targeting a neural structure or another structure? For example, joint, ligament, tendon. There's so many things you can inject in the body. Do you see? Is this an injection or block? And this is a very important question. An injection is basically done through using diluted local anesthetics, and they aim to target the pain fibers mainly. While a block, you're gonna have to use, highly concentrated local anesthetic, like for example, 2% lidocaine or half percent bupivacaine, to block all the pain fibers. And we do this in certain circumstances in non-cancer pain, like medial branch block. We do medial branch block, what we call the double paradigm technique. One time with short-acting local anesthetic, the other time with a long-acting local anesthetic. And this gives us some sort of a prediction whether the patient will benefit from radiofrequency ablation or not. Is this a neurolysis or neuromodulation? Are we putting a chemical or doing a physical modality like radiofrequency to basically ablate the nerve? Or we're doing neuromodulation using a spinal cord stimulator or peripheral nerve stimulator? Is this a regenerative procedure or an anti-inflammatory procedure? So sometimes I put steroids in the joints, and sometimes I put PRP. Of course, there are an algorithm for this. We'll talk about it at the end of the presentation. Is this diagnostic or therapeutic? A lot of times, guys, we do the injection for diagnosis, not for only for treatment. Okay, I need to know whether this pain is coming from the facet joints or not. So I block the medial branch. If the pain goes away, then this is a facet disease. And we see this in pain, a lot because, things can be very confusing. Also, the injection itself could be therapeutic in a sense of its anti-inflammatory effect and the local anesthetic effect that blocks the vicious cycle of pain. And most of the time, we do this injection for both diagnosis and treatment. Okay, another concept. Okay, I want you to think about it. Okay, we have central, pain interventions, and we have peripheral nerve interventions. For example, a central pain intervention like epidural, epidural steroid injection. Okay, this is central. Now, this one is actually more difficult than doing a peripheral All right. It has more complications than the peripheral injection, but the quality usually is better than the peripheral. Okay. Uh, you cannot perform it in anticoagulated patients. Um, the peripheral blocks, let us say, for example, a serratus anterior plane block, okay, or erector spiny block, or suprascapular nerve block. All of these has less quality. Okay, they're not as good as the central ones, but they are safer. So there is a trend, okay, especially in sick patients, to go more peripheral, all right, because of these complications that you might encounter. This is very important, guys, in, for example, patients in the ICU. It's better to have somebody, for example, let us say, with a shoulder pain, I can do a suprascapular nerve block versus an interscalene block, which can end with, phrenic nerve injection, and patient can have problem with breathing, or vascular complications or whatever. So the more central you go, the more complications you have. You get a better quality, and the less and less so with the peripheral, where you get less quality but much safer. Keep this as a concept. All right. I'll give you a case, for example. I had one time a patient in the ICU with shoulder pain. So, and he was actually, his PTT were borderline, all of this stuff. So they asked me to do a block on him. So I chose the suprascap. Okay, I know that this is a sick patient. I'd rather do a simple block and be on the safe side with less quality than the interscaling, for example. But at least I can do it, and I'm not scared about having major complication with such a patient. Okay, so this is some of the, for example, epidural complications like arachnoiditis, epidural hematoma, or even epidural abscess. All right, we're going to talk a little bit about medication. So basically, I had a friend of mine that did this for me. I told him about the medications that I need in my clinic, and he basically I asked me, "What do you need?" So I told him, I need steroids, I need lidocaine, bupivacaine, uh, and different types of steroids. The ones that particulate, like methylprednisolone and triamcinolone, and less particulate like, beta phos, which is beta methazone, and also non-particulate like dexamethasone. If there's so many professors in our field, it makes it difficult, uh, you know, to know which one you're gonna follow. And this is basically part of, medicine here. Um, this was this quote was put forward by Dr. August Beer. He's the founder of the Beer block that we use in anesthesia all the time, original anesthesia. And sometimes we do it for pain. Right now, it's kind of getting a little bit obsolete in pain management, but in old days, we used to do it for complex regional pain syndrome. Also, he's the founder of the Spinal Block. Anyway, what he means in this quote is there are so many schools, and you have to follow one of them at least. Okay, what do you need to know about spinal needles? So the spinal needles are different types, like Quinky. This is the most famous one. Sheba needle, Sprout, Whitaker, Toohey, Crawford, and Max. These are the last three are basically epidural needles that we use for epidural injections. They have a blunter tip. You need to know as an interventionist that the anatomy of the needle. So we have a hub, we have a shaft, we have a notch, we have a face, we have a tip, we have a gauge, we have a length. So before you proceed with your injection, you need to know what type of needle you're gonna be using, in your block. So for example, if you're gonna need to just go very short distance, you should not use long, like 3.5 inch needle. So probably gonna need like 1.5 inch needle. Very important to have a visualization of the size and the length of the needle before you plan to do your injection. These are the Quinky. As you see, they're color gauged. The commonest ones that we use in practice are the black one, the 22 gauge, and the orange one, which is the 25 gauge. But in some places, they use different types of, if they're available. I had a friend of mine used to use the 23 gauge for some reason. I don't think there's a huge difference. The 25 may be smaller, much smaller than the 22, but the 23 is almost like a 22. Epidural needles. Now, epidural needles are utilized mainly for, targeting the epidural space. I really want you to look at this picture carefully here. You have a notch up there, and then you have the hub, and then you have the shaft, and then you have the tip. At the tip, you have a face, you have an opening, which is the face down there, and you have a tip. Your needle, after insertion in the human body, it will, basically move towards the tip. So you need now once you insert it, you will not know where the tip is. You're gonna know it by the notch. So in this example, the notch is in the direction of the tip. So when you put your needle in the patient, you know that the needle will be moving in the same direction like your notch. Okay? The more this bend is exaggerated at the end of the needle, the more the needle will move towards the tip. This is very important because when you do the block, especially deep injections, you're probably going to need to move your needle around so you're able to target your, the nerve or the joint that you're heading to. Radiofrequency needles, okay? As you can see, the notch is in the same direction like the tip as well. And the face is in the opposite side. So again, you're probably going to need to, turn this needle as you get deeper and deeper because it will be going away from your target, especially if you're using the coaxial technique. All right. So we're going to talk a little bit about neurolytic, procedures. So we have radio frequency, we have cryoneurolysis, balloon compression. The balloon compression is used for trigeminal. Most of these physical neurolysis is basically used in non-cancer pain, except the balloon compression, which is used in the trigeminal neuralgia. while the chemical is used mainly for cancer patients, such as phenol and ethyl alcohol. But the only exception is glycerol, which is um, a chemical that's used in trigeminal neuralgia as well. Sunderland classification. This is very important classification to understand the differences between different modalities. So, according to Sunderland, we have first degree and second degree, and these are reversible. Then you have third, fourth degree, and fifth degree. All right, and these are non-reversible. So, for example, if I'm doing cryoneurolysis, okay, uh, probably although it's called neurolysis, but it's actually um, reversible. So, what is the implication of this? The implication is that if I do, for example, a mixed nerve that has both sensory and motor, and then the patient will have some weakness because it affects the abduction of your arm. However, after a while, he will regain back his muscle power. Do you see? So this is important. While if I do a conventional radio frequency, with 85 degrees or 90 degrees, I will get into the non-reversible phase, and this patient will always have weakness in his arm. So it's better to use cryoneurolysis. Pulsed radio frequency doesn't even cause any kind of neural damage whatsoever, and thus it's very safe in patients that have a mixed nerve. For example, intercostal nerve, for example, suprascapular nerve, greater occipital nerve. All of these nerves is better to use, in a reversible technique so the patient doesn't have weakness in his muscles. Okay, and this is basically the nerve composition. I'm sure that all of you guys remember this from old days. You have the epineurium, the endoneurium, and the perineurium. Pulse radio frequency, a non-damaging modality. The temperature is almost around 42 degrees, 45 degrees, so it doesn't cause a nerve damage. And thus, it's useful in these areas, as I said, that has, sensory and motor, innervation. For example, in this case in front of you, they're doing what we call a pulse radio frequency for the dorsal root ganglion. Okay, another important techniques, the conventional RF and the cooled RF. The cooled RF is basically a variation from the conventional RF. And basically, by passing water inside the needle, you create a bigger lesion. And this actually helps the interventionist, to cover a bigger area. And then also, you don't have to worry about the angle of the needle. As long as you touch the area that you're looking for, you don't have to worry about the angle. But with the conventional RF, because it's elliptical, you have to be parallel to the to really damage this. But both of them are basically same indication, sort of. Cryoneurolysis is different. This one we heat, we cool the nerves, okay, and we're using you know, certain probes, uh, and these probes, at the end of the probe, by the process of decompression, you develop an ice ball, and this ice ball is the one that cause the a cryoneurolysis. Okay, the needle itself doesn't have any opening inside. It's just like a solid needle. And the nice thing is you can see the ice ball very nicely under ultrasound guidance. So you're not only seeing the tip of the needle, you're seeing the lesion itself. And as I said, the cryoneurolysis is reversible. So you can use it for, mixed nerves, like intercostal nerve, for example, without fear of getting, for example, a ventral hernia because of the, weakness of the intercostal nerves. I've done this in old days. Unfortunately, when I used it, we used to have these very large probes, like they're pretty huge. But now we don't. We have smaller needles, and thus it became a very lucrative procedure to a lot of people. And this is basically a comparison between the conventional, the pulse, and the cryoneurolysis. Um, and basically, as you can see, the pulse is virtually painless, and you can use it in these procedures like greater occipital nerve, suprascapular, DRG, and intercostal nerve blocks. All right, now we're done with the injections and the blocks. Then we're going to proceed with what we call regenerative injection therapies, where we actually uh, pull some blood from the patient and put it in a centrifuge machine, and then we'll have a plasma on the top of the tube here, and we take this with the uh, with the platelets and inject it uh, in the joints to regenerate the degenerated structure. A very common procedure nowadays. It's a different concept, and this is why you need to know before you putting a needle which procedure you're gonna do. If the patient still, let us say, in early phases, it's better to use the regenerative injection therapy. But let's say the osteoarthritis is pretty late or very advanced, then it's not going to help a lot. Uh, Maybe in this case you use the nerve blocks, okay, and radiofrequency to treat these advanced osteoarthritic cases. Also, there's another similar procedure which is called the stem cell treatment. And basically, we get the stem cell either from the belly or from the bone marrow. And sometimes we mix it even with the PRP and inject inside the joint. And it's more expensive, of course, than PRP, but it's more efficacious as well. All right, we're going to talk about a clinical vignette. I think this will clear up things to a great extent. We have here a 35-year-old male presenting with axial lower back pain for more than 6 months. The patient says the pain is not controlled by medication, and his quality of life is poor. Physical exam reveals pain on extension and rotation to the left. The pain is reproduced on the left side only. Physical therapy was tried, but it failed after 6 weeks. MRI reveals facet, joint hypertrophy, and modic change type 2. There's no evidence of disc herniation. 2 attempts of left L3, 4, and 5 medial branch Diagnostic blockade results in temporary pain relief. This is what we call the double paradigm technique. One time you use a short acting local anesthetic, and the other time you use a long acting local anesthetic. Which one of the following options would be the best choice for the next intervention? Okay, so here, of course, we have a facet or media branch block. And in fact, since this gentleman had a diagnostic block and it was positive, what I mean by positive is the pain relief was more than 75% pain relief. In this situation, you can proceed with the radiofrequency. But it's not, it's not in the choices in this clinical video. Okay, I'll give you some facts about low back pain. First, routine clinical evaluations are unable to provide a specific diagnosis in 85% of the cases. The imaging confirms, but it doesn't diagnose and nor indicate where the pain is coming from. Imaging miss early disc disruptions, early facet degeneration, spondylosis, and arachnoiditis. MRI studies reveal an incidence of a lumbosacral spine abnormalities as high as 50% in asymptomatic individuals. The task force recommended against diagnostic testing, including imaging study for low back pain within the first 4 to 6 weeks, except if we have one of these red flags, like a patient is have a paralysis or has incontinence bladder or stool incontinence. The usual question I love to ask my fellows about: are we chasing the pain or chasing the image? In other words, if you're having a facet arthropathy, okay, on the right side, but the pain is the patient is complaining about the left side, which side you're gonna be handling? Of course, we're gonna have to handle the painful side. We're chasing the pain. We're not chasing the imaging. The imaging confirms the diagnosis, but it's not necessarily the pain and the imaging, intersect most of the time. Sometimes the pain in one side and the pathology is somewhere else. Okay, clinical picture of facet pains. We have tenderness upon palpation. We use this technique called the MRI. I'm going to explain it to you. Provocation testing, the Kemp test is positive. Doing a picture like a CT or an MRI, and then doing the injection of the double paradigm technique, then we will be able to confirm, the diagnosis. These are the lumbar facet arthropathy referral patterns. As you can see, lumbar, lower lumbar, and posterior thigh, lateral thigh, anterior thigh, and the groin. The commonest joints affected in the lumbar area is basically the L4, L5, and L5, S1. This is my regional investigator. I call it the MRI. The Kemp test, or extension rotation test, to diagnose facet arthropathy. Lumbar facet injections. The one on the left is intra-articular injection. And I do this sometimes instead of doing the media branch. Okay? The reason if I inject inside the joint, I can put some steroids. If there's an inflammation, I can do PRP. So it does help me in certain situations. Okay. The media branch block is basically the next step after the media branch will be the radiofrequency ablation immediately. So I'd rather keep it for more advanced cases. The other thing is, I want to explain here 38% of the patients, their facet joints is ossified. So you're not going to be able to inject interarticular every time you see the patient with facet disease. So I usually consent for facet, interarticular, and median branch. And then when I do the X-ray, the C-arm and all that stuff, I'm able to kind of verify whether I can inject interarticular or inject at the median branch. All right, we have false positive and false negative results from these injections. For example, if you're using a high volume, you can actually spread to other adjacent structures. You can get a placebo response. Sometimes patients receive, anxiolytics and analgesics during the procedure. False negative if you're putting the needle in incorrect place. Also, if you have an inadequate local anesthetic volume or concentration, uh, or if you're doing an over traumatic and painful technique. Now we're going to talk about, uh, you know, an algorithm for back pain. So we usually start with conservative treatment, and then we follow this either with the back pain algorithm or radiculopathy algorithm. So if you're having just low back pain, like in this case that we just mentioned, uh, facet disease, then you need to follow the back pain algorithm. But if you're having radicular pain going down in your leg, then you go to the radiculopathy algorithm. So with the back pain algorithm, I'm not going to go through all of this. I'm just going to talk to you guys about the FEST. As you can see, you do diagnostic and therapeutic blocks. You either use the orthobiologics, which is basically the PRP and the stem cells, or you proceed with an RF, thermocoagulation. Or you can do cryoneurolysis. Okay? Now, the radiculopathy algorithm is basically the mainstay here is doing an epidural steroid injection. Take home messages from this presentation. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Peripheral nerve blocks offer less quality of analgesia uh, than central blocks, but with less chance of grave side effects. Pain medicine is definitely a mix between art and science. Thank you.